Welcome to the DiepCFoundation educational channel. I am so pleased today to be joined in this interview with Dr. Joseph Dayan. He's a board-certified plastic and reconstructive surgeon with a focus on breast reconstruction, facial paralysis treatment, and lymphedema surgery, which will be the focus of our interview and this wonderful presentation today. In 2024, he established the Institute for Lymphatic Surgery and Innovation within the Institute for Advanced Reconstruction. Dr. Dayan obtained his medical degree from the University of Vermont College of Medicine, followed by a plastic surgery residency at Georgetown University Hospital. He completed a fellowship in advanced microsurgical reconstruction at Changgung Memorial Hospital in Taiwan. I'm so impressed. With a strong interest in medical innovation, Dr. Dayan also completed an executive MBA from the Massachusetts Institute of Technology. And prior to joining the Institute, Dr. Dayan spent 10 years at Memorial Sloan Kettering Cancer Center, where he established lymphatic surgery and facial nerve programs and augmented microsurgical breast reconstruction. So as I said, he is going to be presenting today a great slideshow on lymphedema surgery. But what I would like to say to the listeners, this presentation is going to be available for surgeons, for fellows who are training, residents who are interested in plastic and reconstructive surgery, and for patients. So we are going to be showing some surgical slides today. I want you to know that. But also, this is really to help patients and provide access to care. We're going to put the information to find the IFAR, Institute for Advanced Reconstruction, information, and where you can also contact Dr. Dayan, because I feel that providing this access to care in breast reconstruction, lymphedema is so important to patients. Dr. Dayan, thank you so much for joining me today.
Thank you so much, Terry. It's truly an honor and a pleasure. It's always great to speak with you. I really enjoy our conversations, and thank you very much for the kind introduction. I'm not on social media much. I'm starting to crawl out of my cave, and this is the most comfortable and best way to do it is with you. I'm very excited to share what really is a collaboration. I'm giving this talk, but this really represents the work of a whole community of colleagues of mine, nurses, lymphedema therapists, nurse practitioners, PAs, and not least of all, and most important of all, the patients themselves. So this has been a unified effort. I've also wanted to give a shout out to the Lymphatic Education and Research Network and Bill Rapisi, who's really championed this cause and I think has brought a lot of awareness, as well as the NLN and other bodies involved in lymphedema. It's a very special time because lymphedema is now receiving attention when it was in the shadows for many, many years and still remains in the medical world a bit in the shadows, but things are changing. So I'm really excited to actually witness this.
Well, and who better to have than the lymphedema surgical microsurgical guru? So I'm so pleased. Do you want to begin the presentation? I'll let you share your screen and we will begin. I might ask you some questions as we're going along.
Sure, please do. I'm gonna jump right in.
Yeah, take your time. Great, it looks wonderful.
Excellent. Let me click OK. Sorry. Sorry, I can't see my cursor. My apologies.
Oh, take your
But
time. I went through this week uploading a video. You have to pause a little bit, and we're all good with that. Modern
okay, but you can
concepts in
see everything
surgical
on
and
the screen?
yes, yes, and I can see both of us over to the side, so this will be wonderful. This looks great.
Perfect. Well, I'll just sort of jump into a little bit of brief background of where I'm coming from. I come from a pretty humble background. I really didn't grow up with doctors or any kind of guidance or push or anything. And I never took any, not money or anything for it. I didn't really have a safety net, and I was very close with my grandmother, um, who I took care of literally until her last breath, and had advanced Parkinson's, to which there's only really one drug, and eventually it stops working. And so long before medical school, I was very sensitive to going to the doctor with her, going to the emergency room with her, going through the medical system with her, and how little time you have with a doctor, and how there's really not much that they were able to do, if anything. And so there are diseases that fall through the cracks. And so I have a soft spot for those, having had personal experience, and lymphedema is certainly one of them. My exposure to this was through fellowship. Mingwei Chen in Taiwan was doing, this was about 15 years ago. He was doing, I think, his fifth or sixth lymph node transplant, when I really never heard of anything like it, and wasn't really being done back then in the US to any degree. There was a lot of skepticism, by myself included, when I first saw it, a lot of concern for safety and how does this work anyway? And then
Mhm.
a quick realization that I really didn't know anything about the lymphatic system coming out of residency and fellowship. So this stimulated, it was a frontier. And almost from a medical standpoint, an opportunity to really help somebody and contribute in an area of medicine that almost nothing was known at that time. And so fast forward 15 years, we've come a long way. And I'm going to share with you, in the next several minutes, fast forward through modern concepts that are still today, most doctors, nurses, and the whole medical uh, establishment, and patients themselves may not be aware of, unless you have a specific interest in lymphedema, or unless you're directly affected. And certainly I would never be aware of if I hadn't had this interest. These are my disclosures. And I'm just going to start with my very first patient in practice. This was before Memorial Sloan Kettering. This was at Beth Israel Medical Center. This was actually a patient referred by one of my mentors, who trained me in residency, who came to see the surgery herself. This was my first lymph node transplant. And this was a very successful woman, ran her own business, no nonsense, did everything right, was 100% compliant, was great friends with her lymphedema therapist, but unfortunately still had progression, was in compression around the clock, and had 3 episodes, major episodes of cellulitis. And cellulitis can lead to sepsis and be life-threatening. And about a third of our patients that we see with lymphedema have cellulitis. So people don't necessarily realize it can be a life-threatening issue. And she was suffering, and she knew that very little was known about the surgery at that time. But her life had changed after breast cancer. She finished breast cancer treatment. She was done with it, but now she inherited a permanent disease. And fortunately, even though we knew very little, fortunately, this actually worked in her, and she didn't require compression any longer, and the limb volume went down, and she wasn't getting admitted to the hospital with cellulitis. She was able to do a lot of things. She flew a lot for work. She played golf. She had a nice country home in the Carolinas. I mean, she was able to get back to her life. And so I only did one my first year. I was terrified, honestly. I was hoping everything I wanted this to work for. And so I went very slow. with safety as the main priority. And I'll get into that in terms of lymph node transplant. But this is really what hit my heart and got me into this. And not everybody responds well. Not everybody's a success story, but there are enough success stories that kept us in the game. And as we learn more, we know better how to pick patients and how to do the surgery.
You
And so
know,
I'm going to,
you just said something. There was enough success stories to keep us in the game. I love that. I love that comment.
well, I think it's very hard. It's hard to tell a patient this is a frontier, and at that time we had no data.
Oh,
This is how we think it works. We have reports that it works. These were case reports, and there was no high-level prospective study. There was no publication on how to do the surgery or even the anatomy. And we had published extensively after looking at imaging. I mean, thousands of lymph nodes we had imaged and published on. But it's very hard to tell the patient, like, I'm going to do my best. And I don't know. I can't give you a percentage. I'd be making it up. That was 15 years ago. And it's hard as a surgeon to do something that doesn't always work. You want to go into your office and see happy patients all day. But I think that for those patients that it works, it was life altering. And even some of the patients that it didn't work on still encouraged us to keep trying, to keep contributing. And you have to figure this disease out.
yeah.
Who's going to do it? So I'm very grateful to those patients that put a lot of faith in us, and all the people that kept us going. These are some modern concepts of lymphedema. I'll just kind of jump right in. And one is the actual what happens to the lymphatics when lymphedema strikes. And I'm going to be focusing on breast cancer related lymphedema, although this is applicable to other types of lymphedema. But most people think that there's a blockage, and there is a mechanical blockage when you remove the axillary lymph nodes. Those lymphatic vessels that are carrying fluid waste up out of the arm into the lymph nodes that have billions of immune cells that then kill bacteria, purify the waste, and then put that waste back in purified waste back in the bloodstream. When you remove the lymph nodes, now the fluid waste can't get out, or at least is partially can't get out. But that's just episode 1 of the story. Episode 2 is the response of the immune system. And for some reason, in some patients, the immune system spews out a bunch of inflammatory chemicals that will cause scarring of those delicate tubes, the little lymphatic vessels carrying the waste, cause more blockage, and also cause them to be leaky, cause the valves in the lymphatic vessels to become dysfunctional. So normally the valves are one way, so lymph can only go from your hand up towards your heart. But when the valves become incompetent, like incompetent veins, they flop back, and now lymph can go back toward your hand. You have leakiness of the lymphatics, where the lymph doesn't stay in the vessel, but just kind of flows out of it into the fatty tissue in the skin. And then you get chronic inflammation. This is all orchestrated by the T cell, CD4 positive T cells. And so there are parts along this pathway that are all targets for potential drugs that have been tried in the past, and also drugs that are being explored currently and in the future. So one question is, how do we cool down the immune system from this abnormal response that's causing scarring, leakiness, and actually fat growth?
Mm-hmm.
The other misconception is that you don't have lymphedema until you see swelling. This is what most patients are told. If a patient feels their arm is heavy, but they show the doctor both hands and arms, and it doesn't look very swollen. And we've had many patients that have told us they were told there was no problem, and it's been a year or 2 years before they're diagnosed. But just like you don't need to wait until you have a heart attack to know that you have cardiovascular disease and that your coronary arteries may not be normal. Lymphedema and lymphatic disease happens long before you see swelling. So this is a woman who's had heaviness, pain, and transient swelling in her fingers. And she was told that she doesn't have lymphedema, but we do something called ICG lymphangiography, which I've been doing now for 15 years in the office. It used to be completely unknown. Now it's more widely known. We do this on every patient we would consider surgery on in the office. We do this, and you can see that even though her hand doesn't look swollen and her arm's not swollen, the ICG shows that there's impaired flow. You can see all that whitish dye building up. That's lymph that's leaking into the forearm. So this disease starts before there's swelling. And just like you wouldn't want to start on a cholesterol lowering medication or any type of treatment for your heart until you have a heart attack, you want to start treatment before you have the heart attack. And the swelling is like the heart attack of the lymphatic system. So earlier intervention is important. The other part of this is that lymphedema is a proliferative disease, meaning that scar and fat build up. They actually accumulate, and the skin gets thicker. Fibrosis just means scarring. Anybody with advanced lymphedema knows what that is. It feels woody, it feels firm. And these are sections of a limb on a cadaver where you can see all this growth of fat in the lymphedema limb. There's a very tight connection between the lymphatic vessels and the fat cells. And so increased body weight impairs lymphatic function. It causes worsening lymphedema. And similarly, on the opposite way, lymphedema causes growth of fat in the limb itself. And that segues into this next slide, which is really important. This was what we published this in 2020, but this is something that, you know, if you look at these two people, these are two women with lower extremity lymphedema, and their legs look about the same size. And typically they would be treated the same. If they went to lymphedema therapist, they would get decongestive lymphedema therapy. And one of the questions is, why do some patients respond so well to decongestive therapy and other patients don't really respond well to it? There's a reason, and this is one of the reasons, is that if you look under the skin, and these are MRIs, black is fluid, white is fat. The one on the left is fluid dominant. You can squeeze fluid out of a limb with compression, but you can't squeeze fat out of a limb. So if you have a patient that has most of their limb volume is because of the fat growth caused by the immune response and the lymphedema, no amount of compression, and certainly a lymph node transplant or lymphovenous bypass is not going to have too much effect on reducing that limb volume. That person probably needs SAPL or liposuction for lymphedema as part of their treatment.
So we're looking at two different patients here.
That's right. That's right. These are two different patients. And, you know, early days in surgery, we would treat them the same. We'd say, hey, we have this technique called a lymphovenous bypass or a lymph node transplant. Let's try it and see what happens. But the truth is now I can tell that the patient on the left who has a lot of fluid, you know, the bypass or the lymph node transplant may have a better effect on reducing that limb volume than the patient on the right, because the lymph node transplant or bypass or even compression and massage are never going to get fat out of that limb. And so we have to understand that not everybody's lymphedema is the same, just like not all breast cancer is the same. There's triple negative, hormone sensitive, HER2 positive, HER2 negative. There are aggressive forms. There are more well-behaved forms of breast cancer. And we observe differences in lymphedema. So no one treatment is a one-size-fits-all for patients. Same for surgery, compression, and probably for drug therapies as well.
Fascinating.
So the reason these are different is from the immune system. There's a reason. We don't understand all of the reasons, but these patients are different. Another misconception is that the bigger the limb, the worse quality of life. And certainly at the extremes, that's true. But there are many patients that we see, we studied, we published on this. We basically looked at patients with different sized percentage limb volume differences, and then looked at their quality of life scores on two different validated patient-reported outcome questionnaires. And we didn't find much correlation at all between the size of their limb and their quality of life. So in other words, you can have minimal swelling but still have a poor quality of life. And the reason we see is that many patients can spend hours a day managing their limb with compression. Some of these patients are getting admitted for cellulitis to the hospital. Many of these patients avoid things they would normally do, like go to the beach, fly to their favorite destination, do aggressive activity out in the sun. They avoid activities and they're caring for their limb. So even though they don't have a large limb, their quality of life is not necessarily so great. So it's wrong to assume that just because the swelling is mild, that patient's just fine. And that patient, of course, is concerned what will happen 5, 10 years from now. So these patients are often misunderstood in medicine. And in the public, much of the public has never heard of lymphedema. I'm going to kind of jump right into the meat of lymphatic surgery. And there are different types of the versions of all of these procedures, but these are the three most common types of procedures you'll encounter. One is, in simple terms, liposuction. In lymphedema circles called suction-assisted protein lipectomy, or SAPL. But this is basically liposuction specifically for lymphedema. It is an aggressive circumferential, radical debulking of all of that fat growth that can be liters and liters and cause massive weight, even causing a joint and back and dysfunction and disability.
Mm.
So this is really for patients who have a lot of fat growth.
Mm.
And then there's lymphovenous bypass, which is an approach that's like a plumbing solution. You're looking at those little lymphatic vessels that are scarred and blocked. You're actually cutting that vessel before the blockage and plugging it into a vein that's nearby. And that diverts that fluid going into the blockage and just leaking into the tissues. Instead of going in nowhere, it gives it an exit and lets it go out the vein and out the arm. And there are also another version called a nodal venal bypass, so you can plug a vein into a lymph node. There are different types of ways of doing this, but bypass, the concept of bypass is basically shortcutting around the blockage. And then there's a vascularized lymph node transplant, or VLNT, or vascularized lymph node transfer. There are different ways of saying this. And this is replacing the lymph nodes that were removed. So you're actually transplanting lymph nodes with a blood supply intact. In some cases, you're also hooking up the lymphatic system, but in most cases, just an artery and vein. And those lymph nodes have growth factors that stimulate growth of new lymphatics into the lymph node.
Okay.
And it acts almost as a sponge. But you're really putting the organ back there. And if you think of the lymphatic system as just like breast reconstruction, if somebody's removing the breast, they're going to reconstruct the breast in many cases. If somebody cuts a nerve, they would repair the nerve. And so this is reconstruction of the lymphatic system. It doesn't seem like the concept should be exotic, as we would treat any other important organ in the body. But the question is, which one do you do? And early on, maybe 10, 15 years ago, these camps were largely almost adversarial. There were the SAPL liposuction people, there were the hardcore lymphovenous bypass surgeons and the lymph node transplant surgeons. And there was not a lot of cross training, I would say 10, 15 years ago.
Huh.
Now that's completely changed.
Wow.
I think
and just to add to, for the listeners who are patients, in the world of breast reconstruction, we think about the anastomosis of blood vessels. This is super microsurgery. I mean, lymph nodes are smaller than blood vessels. Am I stating that correctly, Dr. Dayan?
Yeah, the lymphatic vessels are mostly all sub-millimeter. It's rare to find a lymphatic vessel that's a millimeter. Usually they're in the 0.3 to 0.6 millimeter range, most of them there. If you're lucky, you get something bigger, but usually these are tiny. Blood vessel is usually 2 millimeters, 2.5 or 3 millimeters. So this is sometimes almost a full order of magnitude smaller. You need definitely a special microscope, special instruments, and specialized suture.
And specialized training.
Yes, yeah,
Yes.
yeah. I like not all plastic surgeons are trained in microsurgery to do a deep flap, but not all microsurgeons are trained to do, what's called super microsurgery or submillimeter microsurgery, to do a lymphovenous bypass. And I think it's technically the most challenging thing to do, because you're under maximum magnification. The needle itself can be just slightly smaller than the thing you're sewing to. So I'll share some video of what that actually looks like.
Oh, good.
I'd say that most modern lymphatic surgeons are doing all three of these, and that there's no one size fits all. So depending on the stage of lymphedema that you have and the type of lymphedema, which requires a workup, you may get one or another or a combination of these. It's very common, for example, somebody who's got both extra fat and fluid to get liposuction and a lymphovenous bypass or liposuction and a lymph node transplant, or all three, or lymphovenous bypass and lymph node transplant. So I think modern days surgeons are which is good, using multiple techniques, tailoring it to the patient.
Okay.
And so I would say the low-hanging fruit, so to speak, if a patient is already living in compression, and I know this is not breast cancer-related lymphedema, but there are many women out there with breast cancer who are BRCA positive, have a BRCA gene mutation, and some of which who've had ovarian cancer and can have lower extremity lymphedema. But
Absolutely.
this is an example of somebody who's been living, and this is true for upper extremity, somebody who lives in compression 24/7, has been that way for years, and that's their lifestyle, and has a fat dominant limb with minimal to no pitting. If they're willing to continue using compression around the clock, doing SAPL it will give a dramatic and immediate improvement. This is an example. You can have a very long-term result, many, many years, as long as you're using compression. But it does really require an excellent lymphedema therapist and truly being compliant with around-the-clock compression. I mean, you can take it off for a couple hours for social events or activities, but ultimately you have to be dedicated. Otherwise, it generally doesn't work well.
Okay.
And it is a big operation. For upper extremity, it's same day. For a big volume lower extremity, I would keep the patient overnight. But essentially, it's liposuction circumferentially. It is there's a lot of oozing the first 2 days, but everything sort of dries up, and it does require very close follow-up with the lymphedema therapist. They're the key. We have the patient have a custom garment measured to their opposite limb, but mirrored, and bring that in the day of surgery. We put the garment on. And really, Hakan Borson of Sweden had really pioneered this, and I think had made a great contribution of making this part of our strategy. But this is not appropriate for early or moderate stage lymph, or most earlier to mild moderate stage lymphedema, where you're dealing with mainly fluid issues, and not everybody is able to tolerate 24/7 compression. And so this is more for advanced lymphedema. It doesn't address earlier stage cases to moderate stage cases. Now, physiologic surgery, which is lymphovenous bypass or lymph node transplant, is aimed at the fluid component. And a lymphovenous bypass, also called lymphovenous anastomosis or LVA or LVB, we just say bypass because more people know what that is than an anastomosis. But on the left-hand side, you can see that tiny little blue string that is connected to the big tube. The tiny string is the lymphatic vessel, and that's hand sewn to the side of a vein. So I sewed this to the side of the vein. The blue dye is normally in the lymphatic, but you can see it exiting the vein. There's no blood in there, meaning the lymph is successfully passing through that bypass. And so you're rerouting lymph, like I was describing. The lymph node transplant, or VLNT, in this case, this is omentum and gastroepiploic lymph nodes. These are lymph nodes around your stomach. There's no risk of causing lymphedema, which is why we use them frequently. These are sewn into the artery and vein, in this case in the axilla, to replace what was removed. While we're in there, we can also release scar. Sometimes there's painful contracture there that we can address. Sometimes the axillary vein is compressed, which we can decompress. So lymph node transplant's a much bigger operation. A bypass is outpatient. It really doesn't hurt. It's like 1 or 2 paper cuts with minimal to no recovery. The lymph node transplant does have recovery, but you're doing a lot more. You're restoring the lymph nodes. And we'll get into why you do one or over the other. So this talk, I hope, will be out of date and completely wrong 5 to 10 years from now, because it'll mean that we've advanced the field of lymphedema. So I want to give a caveat that this is just the right now, how we're approaching it. And every year we learn something new. Every year things are going to evolve. So if you see this 5 years from now, don't hold me to any of this. I only hope that I'm wrong, because I only hope we're doing a better job 5 years from now.
Oh my
But
gosh, that's such a statement of hope. I love that.
So right now we've come a long way. We used to not know who's a candidate for what. It was a big topic at all the conferences. Now we have a better idea of at least who we have a higher likelihood of success. And so when patients come to our office who are a potential candidate for surgery, and these are patients that are they're compliant with compression, they're engaged in their own care. Their blood sugar, weight is optimized. Their whole body is optimized. We want to get them non-surgically optimized, both in terms of lymphedema therapy, body weight, blood sugar, in every way, nutrition, before we expose them to surgery, so they'll have a good result. When they're ready to take that step, we would do an ICG lymphangiography in the office. This involves a little injection of lidocaine, which is a numbing medicine, and then a tiny 0.1 cc drop of ICG dye that fluoresces, and they're able to see their own lymphatic system right then and there immediately. So patients that have a visible lymphatic, you see that line on the bottom where you see the big yes, and then it ends in this blush of white. That's kind of lymph that's stuck. That's the dead end. That's the obstruction, the blockage. That person, we can see where the lymphatic is intact and then where it's blocked. That person, I know if I make a cut there, I'm going to find that lymphatic vessel that's scarred down, and I can cut that lymphatic and plug it into a vein, and I can do a lymphovenous bypass. The patient that has the ICG that looks where you see the big no, although I wouldn't say a hard no these days, and I'll explain why, but those patients that don't have a visible lymphatic vessel on the ICG, the state of their lymphatics is probably more scarred, and the quality of the lymphatics doing a bypass may not be as good. And I'll show you what that looks like under the microscope. It doesn't mean they can't have a lymphovenous bypass. We just got a new piece of equipment from Japan called an ultra-high frequency ultrasound that allows us to see lymphatic vessels deeper than the ICG can see. ICG can only see maybe 5-10 millimeters. So even in that upper limb, the patient with the limb that says no, we might be able to detect a bypassable lymphatic on ultrasound. But overall, generally, the quality of their lymphatics is not going to be as favorable. And so if I can see something I can physically bypass, I'll bypass it, because it's a minimally invasive outpatient procedure. And if you can get a good response with not a big surgery, who wouldn't want that? And this is what this looks like under the microscope. So to give you perspective, 1 square is 1 millimeter. You can see the vein on the left. the lymphatic that's scarred, it looks white in the middle. That's not a healthy lymphatic. It's not going to have a lot of lymph pouring out. You can hook it up to a vein, but it's questionable whether that's going to do anything. It's probably lost its smooth muscle that's pumping function, that's pumping lymph up. So it's just a static column. And the pressure in veins is generally higher at rest than in lymphatics, unless the lymphatic smooth muscle is actively pumping, creating more pressure to overcome the back pressure of the blood. The healthy lymphatic on the right that's ultimately gets blocked, that's a lymphatic that I would use for bypass and plug it into a vein. So deciding, there are more of these lymphatics in the patient with the favorable ICG than the patient where you really don't see much. And this is a lymphovenous bypass. This was Kim, an amazing PA that was involved in the case that we did together. The lymphatic is at the bottom of that grid. You see some suture that's blurry, and then this clear vessel. The clear vessel is the vein. Normally, veins are filled with blood. Here you can see it's filled with clear lymph, which means our bypass is open, and that lymph that was once going into a dead end is now exiting through the vein and out the arm. So,
I can see Kim smiling with her eyes.
yeah,
She
yeah,
seems very satisfied with these results and happy.
yeah, it is. I think it's very sad because lymphovenous bypass is very hard, but it's very direct because once you perform one and it's a good bypass, you immediately see lymph flowing into the vein, and that's very satisfying. Um, so, uh, um, and this is a team effort. Kim has an amazing positive disposition. She's upbeat, glass half full, and you need all the glass half full you can get. And I think that's very important to have that vibe and general culture around caring for patients with lymphedema that are struggling. Because we always have to, the more you look half full, the more you can see solutions. And there's different ways to do this: end to end, side to end, side to side. This is an example on a leg. We see the ICG, you see the lymphatic, you see the dead end, the blockage. This is all mapped out. And then we're going to plan our incision before the blockage. So we're making a cut. This is looking under the microscope. That green vessel is the really swollen lymphatic vessel. You can see that thing wants to pop. The purplish vessel is the vein. So we're going to cut that block lymphatic and plug it into the vein. And this when you select a good lymphatic, this is what it looks like. You see lymph pouring out. The green dye, it gets taken up by the lymph. And you can see that lymph was just stuck. It wants to go somewhere, but it can't. It's just going to filter into your arm or leg in this case. So we're going to take that vessel and plug it into the vein. And this is under 40 times magnification using a special microscope with 11.0. Usually we use 12.0 nylon these days, but you can see it's a little shaky because we're under such high magnification. The vessel is 0.5 millimeters, a half a millimeter. This is the highest, magnification you can operate on in anything in the operating room. You zoom in, you zoom out, but now you can physically do this. It's hard to do, but you can actually perform a bypass. And this is like if you blow on the microscope, the whole thing looks like an earthquake.
I know, but you said it's shaky, but I'm looking at the beauty of the stitching. It's spot on. You just nailed it. I love looking at this. Looking under the
It's
hood, I
beautiful.
call it.
It's beautiful. I mean, the lymphatic system is a delicate, beautiful system, and it's nearly invisible. But lymphatics are everywhere around the body. They're in the brain, they're in the heart, the liver, everywhere, and they're probably involved with many disease states. They're looking at Alzheimer's and lymphatic dysfunction. It's probably involved in cardiovascular dysfunction, liver dysfunction. Here, we're checking that the bypass is actually open with ICG, which you can see the dye flowing across. I performed the first lymphovenous bypass in Modena, Italy. I was helping my distinguished colleague Marco Papalardo, who started the program there. We performed this together. And just, I love visiting other surgeons, learning from them, and also teaching and sharing what I've learned. So this was a woman, this is from this patient where I did a end to side. The lymphatic is the small white thing, and you can see the lymphatic vessel pumping.
Mm-hmm.
So lymphatic vessels has smooth muscle, like the gut can squeeze food down. The lymphatic vessel can squeeze lymph up, and you can see the lymph getting pushed into the vein.
Mm.
And I'm not doing anything. This is why choosing a lymphatic vessel is important, that's actually able to overcome the back pressure of blood and squeezing the downstream end of the vein. You can see how much more lymph is flowing through that vein.
Wow.
And everybody's different. It's not the same in everybody. So you actually have to evaluate in the operating room. And this is a patient where sometimes the lymph isn't always going in one direction. In more advanced cases like this, you can see lymph getting congested from both ends.
Oh, yeah.
So you have to hook up both sides. And that's why we would sometimes do a side to end bypass, or we would do two end to side bypasses or two end to end. These are technical things, but all I mean to say is that everybody's lymphatic anatomy in lymphedema is a bit different. And so it's not like one size fits all for surgery. You have to evaluate you can see this is lymph coming from the opposite direction. So I have to hook up both sides.
Dr.
Um,
Dayan, I hope that the Los Angeles Department of Transportation is not watching this. They're going to employ you to figure out their traffic solutions. I mean, I'm looking at this and you talked about how it's just fascinating. Yeah.
but it's such a delicate system. I
Oh,
never
yeah.
get
And so
tired of looking
complex
under the
is,
scope.
yeah, so complex is what I was thinking because you can't just, you're not just looking at one lymph channel, you're looking at all of them and how they're functioning. So thus the analogy of the traffic pattern.
That should receive a Nobel Prize, traffic in LA. Um, so, so lymph node transplant is a completely different strategy. You're not trying to directly reroute plumbing. You're basically planting seeds, restoring the organ that was removed, and those seeds have growth factors that stimulate growth of new lymphatic vessels into the transplanted nodes and then out the vein. Um, so why would you do a lymph node transplant? Um, when would you do one? There's some, as I've gone down this road, I think there's still gray zone. I think there are patients you could do either a lymphovenous bypass and a lymph node or a lymph node transplant or both. And there's no necessarily wrong or right answer. And it's hard to compare both. It's impossible to ethically really do that study and tell the patient, we're going to randomly select you for either an outpatient operation or an inpatient operation, and that patients would actually sign up for that. So
Yeah.
it's very hard to answer the question, who does better, a lymphovenous bypass or lymph node transplant? Usually there's some selection bias in that usually more earlier stage lymphedemas are being done with lymphovenous bypass and later stage with lymph node transplant. Although I have done early stage lymphedema with lymph node transplant that have done very well. So I think this is still an area, frontier and a gray zone that needs to be clarified. But there are some patients that I think would definitely benefit from a lymph node transplant once I see him in the office. And that is the patient that has a bad contracture and pain in their axilla. They can't do their hair, wash their hair. They've been radiated and they're stuck.
Wow.
Um, so those patients doing a lymphovenous bypass is not going to help the pain and contracture. And if that pain and contracture is bothering them just as much as the lymphedema, for me, it's a straight to lymph node transplant because there's an opportunity we can remove all that contracted scar. And these are patients, they've already done exhausted physical therapy, but
Mhm.
that scar, radiated scar, is like, it's like concrete. So I would remove all of that scar, which is a big deal to remove that, get their range of motion better. If their axillary vein has a high grade narrowing, also that's not going to be great for lymphovenous bypass if you're plugging into a vein that's nearly blocked. We have to decompress that vein. So also patients who have a narrowing of the axillary vein, I do a lymph node transplant and decompress the vein by removing all that scar, put fresh, soft, non-radiated, healthy tissue and lymphatic tissue, get them back into therapy, and you can kill two birds with one stone, treat the lymphedema and the contracture. And also, some patients you just don't see any great bypass to, or the bypass really didn't work. I think those are other sort of hard cases for lymph node transplant.
Okay.
For earlier stage lymphedema, whether to do a bypass, is that better than a lymph node transplant? I don't think there's data that can say one way or another, and I think it's really case by case with your doctor. We do know that transplanting lymph nodes, you do get new ingrowth of lymphatics. So this is a lymphoscintigraphy on the left. I transplanted the lymph nodes to the calf, and you can see that dark spot where the arrow's pointing. Those are the transplanted lymph nodes in the calf. This patient had a technetium injection in the foot, and yet it got uptake into the transplanted lymph nodes, which means that there was definitely new lymphatics that went from the foot to the lymph node. They find their way. So we've confirmed both in animals and in our own patients that the transplanted lymph nodes actually do work. One of the biggest critiques, one of my biggest concerns, along with everybody else's, is, why would you take lymph nodes from someplace else in the body? Aren't you going to cause lymphedema, which would be catastrophic? If you took groin lymph nodes and caused lymphedema in the leg and put them in the axilla or the upper extremity, that sounds like malpractice. Like, what are you even thinking? And if you're not really looking at the lymph node drainage pathways, then you're flying blind. We would do this. We first published on this technique, and I really was looking at the breast surgeons. This was described as early as the 1970s by Holtborn, and then popularized by Suzanne Klimberg and modernized in doing axillary dissections and mapping out which lymph nodes drain the arm versus which lymph nodes drain the breast. They're not always the same. And so what we would do, say we're taking lymph nodes from the groin, I would inject technetium, like this, what they inject for sentinel node. And in the operating room, I have a little Geiger counter, a little probe, gamma probe. We can find which lymph nodes are draining the lower extremity and avoid them. And then we have a different dye and inject the trunk. And I can cherry pick lymph nodes that are not draining the leg. And so we first described that and published that in 2014. And I think there are different forms of this, but I think that would be a standard of care in terms of safely performing this. And with doing this, we have not observed any donor site lymphedema. And we've been taking lymph nodes from the groin, the axilla, the neck. Submandibular or submental lymph nodes don't have a risk of causing lymphedema. The neck, if minimal, don't have much of a risk, if at all, of causing lymphedema. But this is a technique that allows for safe transplant. Our number one donor site, though, has no risk of causing lymphedema, and that's why I like it, is the Omentum and gastroepiploic lymph nodes. These are inside your abdomen. The Omentum is a carpet of fat chock full of lymphatic tissue and growth factors. It's just a lot of surface area. It's a great blood supply, and it's very versatile. You can reach to blood vessels in very difficult situations. You can tailor this to the defect. It can be as big or as small as you want it or need it to be. So we've done hundreds of these and published on this as well. And also published on how to do this well. So you really usually need 2 venous outflows to reduce any venous back pressure. There are all kinds of technical pearls we've discovered along the way, but it's not always a solution. Mainly in patients where you need skin replacement. This is a patient with a multiply recurrent cancer in the groin, previously radiated, will get radiated again, has severe pain, contracture, and needs all of the skin removed, had her axillary artery, axillary vein removed. I mean, this was a huge, basically almost an internal amputation, aside from her femoral nerve. Her blood vessels had to be reconstructed. The entire
Mm.
lymphatic system was gone. She already had lymphedema preoperatively. Normally, after this kind of surgery, you would expect her to have like elephantiasis of the leg. I mean, but we were able to loop blood vessels from the opposite leg, did a lymph node transplant from the back with lymph nodes from the side. And even though she still has lymphedema, she's still walking 5 miles a day. Her lower leg and foot didn't become like elephantiasis, and she was pain-free.
Mm.
After that massive resection, you're going to expect to see something pretty bad. This is a patient with severe lymphedema of the upper limb. You can see the radiation contracture. You can see that thing, that blue thing down there is the axillary vein that's not in continuity. It's not going anywhere. So blood's not getting out of the limb. In cases like this, you can't do an omentum. You need the skin. So this is skin from the back with vascularized lymph nodes, greater saphenous vein grafts, restoring the axillary vein. This was a big, complicated surgery I did with my colleague Mark Smith years ago, and restored both his venous and lymphatic circulation. And you can see the lymphedema therapist now is able to get lymph out of that limb,
Wow.
where before it was just about as ripe as a watermelon.
Mm. Amazing.
And um, so I'm going to take a pause because I'm just think I just did a marathon of speech, and I don't know if you have any thoughts, Terry.
Oh my gosh, I've learned so much. I don't know what to ask you now because I've taken notes here and yeah, this has been fascinating. It has been fascinating. My mind is full.
Yeah, I think I feel bad because sometimes I'm talking and I'm not I'm not sure if I'm putting everybody to sleep. I
Oh, you
certainly get
haven't put
sick
me
of
to
hearing my
sleep.
own voice after a while.
No, I've been taking notes here. I think, one of the things that you have emphasized so beautifully, other than just, I mean, I love looking at the surgical transformation and what you're doing surgically, the transformation of the patients. Um, it's specific to each patient. So the surgeon really has to, excuse the tongue in cheek, but flesh out really what's going on with the patient and know which method is going to be appropriate for them. But I guess I wasn't as familiar with the three different methods until today. I've heard of all of them, but you really explained them well.
Thank you. This is really esoteric stuff, so it's a lot to wrap your head around, and there's so much more, um, but I'm happy to hear that it's not, sometimes it's hard to know when you're describing these things that most people, even in medicine, have never heard about, let
Mhm.
alone to general public, if you're kind of making any sense, or if you've just been talking to yourself in the cave in your PowerPoints or keynotes. So I appreciate the feedback, and certainly if anything's not clear, let me know.
Well, this again, just to emphasize, I told you before we started recording, Dr. Diane, that I met the people at IFAR, the Institute for Advanced Reconstruction, I guess about a year ago or so, and have been learning more and more about it or them. But the beauty of this to me is the collaborative work that you all are able to do in this, because that's what's going to ultimately benefit patients. So I'm hoping that, you know, we're able to share this and have you collaborating just by having patients or having other surgeons watch this. We're going to have the information to get a hold of you. So,
Well, I appreciate it, and I, I mean, the reason why I joined the Institute for Advanced Reconstruction is is to be able to work beyond the walls of any single institution or any
Mhm.
building. This is it's the largest private reconstructive group in the nation. I think that there are many great institutions out there. Certainly Memorial Sloan Kettering, which I'm deeply grateful to. And together we were able to build great things. It's my dream to really build something as large as the potential that I can reach and contribute. And I love traveling and working with different institutions, different surgeons, and we're all under the same umbrella. So I visit other surgeons. It's very hard for plastic surgeons to collaborate. Everybody's, they've worked on their career, they've developed themselves, and for a whole bunch of reasons. But I love, I love being open with what I have, good and bad. I'm looking to always get better, and I love surgeons that are also like they're at the top of their game and they're honest with their outcomes, with their successes and their failures.
Yeah.
And only then can we really advance the field by acknowledging honestly and with high fidelity what's working, what's not working. And so the goal is for this, we've started this Lymphatic Surgery and Innovation Center, and innovation is a big part of it because future technology is really the key to solving problems we can't solve now.
Mhm.
And we're collaborating with Brandon Dixon of the Dixon Lab and a whole collection of his colleagues and preeminent engineers that are interested in lymphedema, which is exciting. So we're working as the clinical arm with them. I love traveling and looking at new technologies that might help a patient. And IFAR is, it's a dream. We just got a brand new Mitaka microscope, ultra high frequency ultrasound, ICG in the clinic and in the operating room. We have 2 full-time nurse practitioners specifically for lymphedema. We have a whole lymphedema team, multidisciplinary team. I'm just blessed. We have a full-time researcher, and we just hired a PhD who is at the Karolinska Institute in Sweden for many years, who ran big-time clinical trials. So I'm still able to do high-level academic work, not limited to any institution, but and have the agility to build beyond my own practice and hopefully internationally. So it's exciting. One of the big questions, and this is kind of a key question, and it took maybe 10 years for me myself to really answer, is does lymphatic surgery actually work? Does it
Yeah.
actually work? And it can be hard to interpret the published data. And now we have the benefit of a lot of now prospective data. Like I don't think there's a question that these procedures work. I think really the question is in whom do they work, in whom do they not work, and how best to do them. But from the beginning, even though I had happy patients and it looked like it was working, when you're trying to measure like lymph volume as an outcome, not everybody has a big lymph volume difference. So using lymph volume in a person that has recurrent cellulitis, is well wrapped and in compression, but doesn't have a big lymph volume difference, lymph volume doesn't become a good necessarily indicator. In those patients that do have a big lymph volume difference, if they come see you and they haven't seen a therapist for a long time, and then you do surgery, and then you send them to the therapist after surgery, well, the therapy is certainly going to improve their lymph volume. Maybe the surgery also improved it. Maybe it didn't. Was it the surgery that made them better? Was it the therapy? That's the biggest confounding factor.
Mhm.
And so we've studied this prospectively, and we actually are going to publish our 4-year outcomes. This is 2-year outcomes. But basically, we would first send them to lymphedema therapy, have them maximally compressed in their very best state, then take our baseline lymph volume measurement. Then we would do the surgery, and then we would measure lymph volume. So many of them would not necessarily be as compliant, and that would stack the deck against us. But certainly if their lymph volume went down, we would know 100% that it was the surgery.
Mhm.
So that's how we did this. So we biased the results against us, but we did find, and we looked at bioimpedance and cellulitis, need for compression, all of this stuff. I'm going to kind of whip through this, but this was 89 patients, mean follow-up of 2 years. Now we have a mean follow-up of 4 years, but quality of life outcome scores, basically 3 out of 4 patients have a significantly improved quality of life outcome. Cellulitis was significantly reduced by annual incidence, significantly reduced. Volume difference is improved significantly in about 50% of our patients. Same thing with LDEX. And about a third of patients no longer needed compression with upper extremity lymphedema. So that's kind of the summary of our outcomes. That's not a 90% success rate, but that's a very honest stacking the cards against us, eliminating post-op compression as a confounding factor. That's the first study to really do it that way. And this was a note from a breast plastic surgery colleague at Memorial about a patient I operated on hers who she texted me and said that she saw her and after surgery, she never needed to wear a sleeve anymore. And, a kind note. So these are real patients that's a life-altering thing. Here are some cases of improved lymphedema after surgery. This is another case of a patient who had lymph node transplant. And I also want to share a failure. This patient's swelling got a little worse. And once in a great while, I think it would be false to represent surgery as always being successful and there's no downside. There's no such thing as no downside to any intervention. You can have chemo that may not prevent a recurrence and not rid yourself of breast cancer and can give you serious toxicities. You can have all kinds of risks from all kinds of things. But overall, a lot of the early learning curve these days, I would say that lymphatic surgery is very safe. These are very honest and sober outcomes. And this is combining them, you can get a much better result. This is liposuction and a lymph node transplant. And if you look at her hand is much better. That's not from liposuction. We don't liposuction the hand. That's from the lymph node transplant. And that's at 2.5 years. So we combine these procedures. And then the final part of this is, can we avoid lymphedema? Much better to avoid it than to try to treat it. So we've done spearheaded, my colleague, Dr. Michelle Caridi at Sloan Kettering had spearheaded a randomized prospective trial for immediate lymphatic reconstruction at the time of axillary dissection with lymphovenous bypass. I was privileged to collaborate with her. Doing this, we basically found 1 in 3 patients had lymphedema who didn't have reconstruction, as opposed to 1 in 10 patients roughly who did. So this is a real thing to consider for patients, reconstructing the system at the time of lymphedema. And even patients who have axillary dissection, we use ICG to monitor them. So you can see this abnormality that happened about a year after axillary dissection. And then 8 months later, she had clinical swelling. And then we were able to, do the lymphovenous bypass on her and treat it. Can we avoid pain and contracture? Instead of waiting for something like this to happen, for very radical axillary dissections, we'll actually put Omentum at the time of the axillary dissection. So this is for patients with really bulky disease or recurrent axillary disease, where there's going to be a real aggressive clean out. And this is a patient who got radiated after, had immediate Omentum. She normally would have pain and contracture, and she's doing yoga without any problems. And she had bulky recurrent disease. This is a patient with immediate reconstruction using an Omentum. She was radiated. She doesn't look radiated. She doesn't have a cosmetic deformity, no pain, no contracture. And this is a patient who had immediate reconstruction on the left, but not on the right. The left was fine, the right was not. And basically, the way we figure out who's a candidate of lymphatic surgery, or your veins have to be in good shape. You have to be engaged with your care with a lymphedema therapist. And we want the body weight and blood glucose optimized, because we know they will negatively affect lymphedema and negatively affect the benefit from surgery. We don't want to expose you to risks of surgery without a good benefit. So we want to optimize them, get them in fighting shape, and then and then do surgery. And of course, understanding realistically, we don't have a cure for lymphedema, but we're going to do our best. This is not in the realm of science. This is in the realm of frontier, but I know we spoke about it, Terry, and I think this is very exciting potential avenue. So we just published the first case report of treating a patient with lymphedema using GLP-1 receptor agonists. I have no disclosures here with pharma, but these are drugs like Ozempic. A generic is called semaglutide, but most people don't know what that is. I am actually on semaglutide for diabetes, but this is effective treatment for weight loss. Also, Wegovy, Mounjaro, all of these classes of drugs have an effect on both insulin resistance as well as weight loss. And we know that significant weight loss can reduce lymphedema. This was a patient I treated with Dr. Emily Gallagher at Sinai. She's a esteemed, distinguished endocrinologist. This patient, we were following prospectively limb volumes, bioimpedance, quality of life. She was in our non-surgical arm. She had breast cancer, was treated with chemo and hormones. As many women do, she put on weight after this treatment that disrupted and distorted her metabolism. Many women are still eating and exercising the same way, but all of a sudden put on 20, 30 pounds after cancer treatment. And her lymphedema blew up. She had very mild lymphedema, bless you. And then the arm blew up. I worked with Dr. Gallagher, who prescribed ultimately semaglutide. She lost about 25 pounds. And with the weight, her lymphedema essentially almost normalized. And she was in compression around the clock previously, and she no longer needs compression. And when you speak to her, she's really, I mean, she's absolutely thrilled. So this is not scientific. This is just a case report. And I want to highlight that we need prospective data.
Yeah.
We also need safety data. The safety of these drugs has been widely studied. There are now large studies. The effect of these drugs on cancer, risk, recurrence, all of these things have been studied. And I would say that there are some conflicting reports, but I would say largely the largest studies have shown these to be fairly safe in very large populations. But this is something to really discuss specifically with your doctor. We're not right now endorsing the use of this. I'm not an endocrinologist, but I did witness now probably a dozen patients who have reported to us, and some of which we actually have data on, prospective data on improvement in their lymphedema. Certainly, there are many patients who are not candidates for lymphatic surgery that could become candidates for lymphatic surgery with weight loss, ideally treated with diet and exercise. But some of those post-breast cancer weight gain can be refractory to conservative means. So there's also evidence that this drug directly affects the immune system. This drug actually affects the CD4 positive T cells, that this drug can directly affect pathways that affect the actual lymphatic vessels. So there may be direct effects on the lymphatic system. This is a frontier, and we're right now engaged in starting a prospective study, which is really what we need.
Yes,
So
those prospective studies are so important. Yeah, you talked
yeah,
about that earlier. Wow, fascinating stuff.
and I want to thank you, Terry, very much. Thank you for your patience. I'm sorry I kept talking too much. And
Don't apologize. I love your, yeah.
many thanks to all of our patients, and all of our colleagues, our team at the Institute for Advanced Reconstruction, and Lymphatic Education and Research Network, which has really done a lot of great things, and all of the other too many people to thank. But thank you so much, Terry.
Thank you. I mean, I've learned so much today and I took so many notes. I think one of the key things that I took away from this for patients, you spoke about this, they have to be committed. This has to be a commitment on their part to work with their surgeon for the improvement of lymphedema, no matter what, course of treatment is given.
Yeah, I agree. It's just like I know I had like I got the calcium score, the CT scan, and my calcium score is high. And taking a pill alone is not enough. Modifying what I put into my body, what I'm doing to optimize the whole body, um, is important. It really alters over time the trajectory of where one might be for any disease process. And I think especially if you're dealing with a frontier where you can't guarantee a result, you want to give that patient the maximum benefit, and you want to carefully choose the patient that will have actually a good outcome. In the beginning, I learned the hard way, compassion alone and having good intention and operating on anybody you felt bad for is really can actually expose them to risks without any benefit. And that was at a time we didn't know much. But now I think with imaging, we're able to see and understand the differences in patients, not only their physical differences, but also how engaged they are, as you say.
Yeah. Well, thank you again for this wonderful presentation today, all this information, and just hearing the passion in your voice about this. Very hopeful.
Thank you, Terry. It's a privilege and an honor.
All right. Well, thanks so much for joining me today. I really appreciate it. Dr. Joseph Dayan at the Institute for Lymphatic Surgery, which is part of the Institute for Advanced Reconstruction. I think I've lost my voice. It's time to go.